Welcome, welcome. I don't see you. I was gonna say it's good to see you. It's good to have you here. My name is Amy Lukes, and I am the director of AOT implementation. And we're very lucky to have these two. Well, I know there's a lot of us. Most of this is the AOT implementation team at TAC, and we'll introduce them. But I just want to say thanks to Kana Lastovica and Jessica Mays, who are our panelists today. We did have another panelist who had to cancel due to an emergency. So um, sorry about that, but I think these two folks can cover and answer any questions you may have. We're going to do a quick, well, not a quick, we're going to do a Q&A, a facilitated question and answer, and then we will take questions from the audience. And you can do that one of two ways. You can put your question in the chat box, or you can use the Q&A pod that on my screen is right next to the share button. And Ashanti will be our Q&A facilitator extraordinaire. So just as a way, I'm the director of the implementation team, and I am a social worker. And I'm sorry, I got distracted by a hand being raised. My expertise is in the clinical side of AOT. So, Betsy.
Good afternoon, everybody. My name is Betsy Johnson. I've been with TAC for about 9 years now. I am the Senior AOT Policy Consultant and look forward to working with you all more in the future. Thanks for being here.
Sarah?
Good afternoon, everyone. My name is Sarah Hyatt, and I am Senior AOT Legislative and Policy Counsel. I'm a licensed attorney and registered nurse, and I have a background in overseeing a large AOT program in Cincinnati, Ohio, Hamilton County. And thank you so much for being here with us today.
Jared?
Everyone, I'm Jared. I'm our senior AOT advisor. I work on our training materials and resources. I originally prior to this, was working in an inpatient state hospital. And thanks for putting up with all my emails and reminders about this webinar.
Ashanti.
Hi, everyone. I'm Shanti. I'm the research advisor on the team. So I have a research and data background, and thank you all for being here.
Last but certainly not least, Brooke.
Hey, everybody. Good afternoon. My name is Brooke, and I am the AOT implementation manager on the team. And I manage our resource offerings through the AOT Learning Network.
And we will put in the chat, we will put in a link so that if you are not yet a member of the Learning Network, that you can do that, because it's very helpful, I think. All right, team, we'll see you later, and we will, hold on, let me just, there we go. That's better, just the three of us. So, all right, let's go ahead and get started with questions. I'm gonna start with you, Kana, and then we'll go to Jessica. Basically, I want you to introduce yourself and describe your SAMHSA project.
Okay, great. Thanks. My name is Kana Lastovica, and thanks for having me today. I work for the Houston AOT program. I am actually the project director of the AOT program with the Harris Center for Mental Health and IDD. We are the local mental health authority for Harris County, which is the very large county serving Houston and the surrounding areas. Our grant just ended at the end of the summer. We had a 4-year SAMHSA grant, And we use those funds primarily to, we prioritized the evaluation project and salaries for the treatment team. I don't even think that it completely covered all of our treatment team salaries. So that is where our funding went for the past 4 years. We were, as part of the grant, we required to enroll 30 participants per year, per grant year. We actually went well over that amount. We typically had closer to 40 or 50 new participants per year. I think because Houston is so heavily populated, Amy and I were saying it's over 4 million people. There's a lot of need here. So I think I've heard some programs talk about struggling with getting participants and referrals. Our problem was really more of the opposite. It was kind of out of all the referrals that we had, having to really only have space to accept a smaller percentage of those referrals and trying to pick out referrals we thought would really benefit from the program. So we did about 40 to 50 per grant year for the past 4 years, and we are really continuing on that same pace this year post grant. And that's our program.
Jessica.
I'm Jessica Mays. I'm with the Kansas Department for Aging and Disability Services. I'm the AOT program coordinator. So I am actually with a state agency and I oversee our 5 AOT pilot sites. Actually, it's 6, but one of those is COVID funded. The other 5 are all SAMHSA funded. So my role is to be there to communicate, handle the paperwork, and be an ear for my folks in the centers that are actually boots on the ground and working through. Our 5 centers vary. They're in 5 different counties, and they are all spread out throughout the state. Most people don't know about Kansas very much, but the farthest distance, we've got centers that are about 5 hours apart. So it's not like we're in a central city. So whereas Kana does urban, I have a lot of rural. Our centers are small. Our counties, we have 105 counties. So 5 of those, I watch over their AOT program. But we are gold. Let's see, we were supposed to do 50 a year. And of course, we're on year 4, which means we started smack in the middle of COVID. So we're technically really on year 3. We've hit about, well, it gains a little bit each year. Right now, I think we're queued up to meet 50 this year. And that does vary by region. Each center is supposed to bring me 10. That's not the case. I have some bringing 30. I have others bringing 5. So it does, equalize out, but it also depends on the population and how large that area is. And so for funding, what we've done is our budget is a 40-page budget for SAMHSA, just to let you know. But we've prioritized gap funding for insurance because not everyone has private insurance. And Kansas is not a Medicaid expansion state. So we have that gap. So we use funding to fill in those blanks. Staffing, priority. And of my 5 centers, I may have 13 people listed on one list and 3 or 2. I got one with just one person listed as salaried on the other. And those range in greatly in cost as well. So it depends on where you're at. But those are where we focus the most. Some of ours goes to attorney fees as well.
And Kana, does your funding go to the courts or attorneys at all? I don't think it does. Follow-up question to Kana. You also, I think you started or you got notice of your grant in July of 2020. Was your did you meet your goal your first year? You did.
Yes, yeah, we exceeded our goal our first year as well.
Let me just say to all you grantees wondering how the heck, um, Kana is one of, I mean, that was very unusual in that 2020 class of grantees. Many were struggling to get anybody in that first year. Um, Jessica, you started after the first year, so the first year went by without much progress. Um, did your GPO have any, I mean, were they pressing you for um, making your numbers?
No. In fact, we haven't been pressed to make our numbers until this year. And I there's some confusion as to that. But no, the first year was a mess because we had staffing issues. So not only did we have COVID, but we had staffing issues both at the state level because I wasn't here for the first year. And that position sat vacant. So we had the staffing issues, and then we had the staffing issues in the centers. And to be honest, it wasn't until we got the CCBHC models put in place that we actually were able to fill all of our spots. But no, there hasn't been a lot of pressure because, again, since we got the year late start and explained it, they've tended to allow us a little more grace.
Yeah, and to be clear, that I haven't heard of any grantees who felt like they were going to lose their money because they didn't have their numbers. It wasn't like that at all. So project directors have very different roles in these AOT grants. Some are only involved in administrative portions, and Jessica, that's mainly your role is making sure that your sub grantees are doing what they need to do. And I'm I'm just going to put it out there, pushing the SAMHSA paper around because there's there's a lot of paperwork.
Mhm.
Are there other parts to your role that
I think one of the biggest things that it's not really part of my role, but it's something that's developed organically. My grantees know that they can call me, they can text me, they can email me, and we can talk, and not on a professional level and you know, we're on the same level. If they want to vent, I'm there to listen and to try to advise. There's certain things that I can't advise on. I don't have a degree. I don't do clinical work. Oh, I have a degree, just not in clinical work. Let me rephrase that. But if they're frustrated and if I can't help them, I have 5 centers. There is someone in those centers that can help them. We've developed an AOT network, and all of my people are willing to pick up the phone, call each other, advise, help, assist. It's a peer-to-peer network. And not only have we done it for those 5 counties, but we've also done it for new AOT programs. And so we got 105 counties. That's a lot of courts, a lot of CMHCs. And granted, they all have districts, but you have to deal with each court system separately because each judge is different. So my judges will call other judges. My DAs will call other DAs. My clinicians, my caseworkers, they all call each other and they talk and they figure out what's the best way to set up a new program for this area. Because like states, counties are all different. So we've developed this network where we have statewide meetings and we have everybody show up. Last call, I think we had about 85 that showed up. And that's anybody who's interested in starting an AOT program. The judges have their own calls that they do on their own. The caseworkers have their own call that they do on their own. We've really developed this network where not only is it welcoming, but they can get a jump start on AOT before they start moving through it.
so a convener is a huge part of your role. And
Yeah.
I know we at TAC really appreciate that because state networks are so important in terms of support.
Mhm.
So, Kena, what's your role at the Harris Center with regards to AOT?
So my role is designed to be the clinical leader of our treatment team. So very hands-on. Our team meets almost every morning to staff with our psychiatrist and to plan out the day. And I am involved in kind of every aspect of the supervision of the team that provides services to our participants. We have 9 care coordinators, 2 therapists, a peer, and 2 clinicians who are at the hospitals. And I am involved with all of their activities throughout the day.
Um, do you deal with SAMHSA
Yes.
quite a bit?
Yes.
So
And then
you do.
all of the paperwork and AOT related meetings and documents and SAMHSA and all that. Yes.
All right. I'm going to list some barriers to implementation that we heard from the last cohort of AOT grantees. And I'm just curious about your experience with this. The first one is getting collaborators to the table, making sure that everybody is there and has a say.
You mean stakeholders? At least that's
Yes,
what they used to be called.
yes,
Uh,
exactly.
well, I think working with smaller jurisdictions helped us out a little bit because we know our people. So, working out of the community health center, they were able to reach out to the local sheriff and the local police department. And they know the DA. Finding the judge, though, I think was the most difficult thing because you have to find the right judge. We have a county where they have the wrong judge, and that program will not be continuing. So the right judge with the right mindset, with the openness to take it on was a big deal. We have groups. It's once the original stakeholders are in place, it's amazing how fast after that first year and they start seeing the changes with the participants, how fast that stakeholder base grows because suddenly other people want to be involved. And that's great. We've got one group that has most of their local charities that would be in touch with their, with their community health center involved, be it Catholic Charities or, the local rescue mission. Um, they're there, they provide support, they donate housing. So once you get that initial core group there, and it's sometimes it's a matter of figuring out which person works because your local PD, you may have someone who's very anti-mental health and you may have somebody else who's like, put me in, boss. No one wants to be voluntold. So it's a searching process, and knowing your community helps, and asking for referrals helps, and getting them on early helps.
Kana, you have a very robust stakeholder group in Houston.
Yes. Yes. And they're very committed to the program and really believe in AOT. And I've seen that, as Jessica mentioned, really grow over the first year as we started to really see some client success. We had client success stories and things started to really work well. You could kind of see that belief in the program grow. I think for us, the group of collaborators, they were really all already involved and together whenever I was brought onto the program. But we did have, I believe, previously a couple of abandoned attempts to start an AOT program in Harris County. So my understanding is there was maybe a little bit of skepticism coming into it when the SAMHSA grant was approved, but definitely it kind of took that first year. But I think that we do have a really strong group of supporters, and like Jessica mentioned, also our judges are wonderful and very committed, and I think that's made all of the difference for us.
getting appropriate referrals. Kana, you mentioned that it's not necessarily a lack of referrals, it's making sure you have the right people.
Yes, yeah, and that's been an ongoing discussion for us. Definitely, it continues to be trying to find referrals who we really believe can meaningfully participate and benefit from the program. I think the thing that has made that really workable for us is that I have a therapist who is housed at the hospital at Harris County Psychiatric Center, where all of our referrals come from. So she's in very close contact with the psychiatrist there, with the social workers, having those discussions, giving presentations, sometimes attending their meetings and keeping AOT kind of on the forefront of everyone's mind and talking about like different clients who might benefit or who may not really, and other options for them. So she's developed a really close relationship with all of the staff there. And I think that's helped us kind of refine our process as much as we have over the past 4 years.
And just to be clear, all of your referrals have come from the state hospital, with the exception of a handful.
Yes, the county hospital, and then another, there are actually two. We added another one mid-grant. And we've had, you're right, there have been a few exceptions, but 95% have come from those two inpatient psychiatric units.
Jessica, you don't get referrals yourself, but you hear from the people on the ground.
Right. So Kansas has 2 state hospitals. We don't have county hospitals. We have 2 states. And they are basically east and west, but that's not always the way jurisdictions work. So referrals, it was a bumpy process to start because in Kansas, we have outpatient treatment programs, or well, an outpatient treatment order, which is the basis for our AOT. And many of you probably have that. It was a law that kind of went crazy in the 90s. Everybody seems to have an OTO law. But there was skepticism because it wasn't utilized properly. The hospitals would put someone out on an OTO, and that person would sit on it for 2-3 years. So, or more, or lifetime. I mean, they just never got off of this outpatient treatment order. And they weren't seeing a judge. They weren't doing anything productive with it other than the fact that they could be thrown back in the hospital at any time if the judge so deemed. So convincing that this mindset that AOT was not an OTO, or at least a normal OTO, took a lot. And again, we had to bring the judges to the table and the DAs to the table. And they had to actually go in and convince the hospital staff that this is not what we were doing. So the hospitals would then work with my centers and their liaisons to get us referrals. It was quite the ball of wax. But so our referrals came from the state hospital. And once those started flowing and they started seeing progress, and the hospitals started realizing that their intake rates were going down, especially the recidivism rates in these counties, they got on board. I now have some counties that have more referrals than they can deal with. Others, it depends on population. But it was a matter of convincing them that this is not the old process. And a lot of that is education and talking and getting with your hospital officials. And it's got to start top down. You can't go bottom up. And convincing them that these counties are not the same as the other 105. And so we started there. And then we also went to the state legislature and changed the law. So now we have in place the ability to take someone before they become a danger to themselves or others. And that's the stickler, is they do need to have a history of mental illness. They do need to know that this is a pattern. This is something they've seen before. They have to prove this to the judge that this is the way this goes. And then they can be put on an outpatient treatment program and enrolled in AOT. But it's, second or third hospitalization. But we can now get them before they decompensate to the point of needing to be hospitalized if they have that repeat history, which is big because it's the only thing that we have in Kansas that allows us to get to someone before they're a danger to themselves or others. So we are starting to see that come into play.
That's huge. That's huge. And shoot, there was something I was going to say, but it just flew out. But all right, I'm gonna change gears here because this is turning out to be a really rich conversation. I don't want to miss some of these things. So, what tips do you have for new project directors? So the folks that are on this webinar, I believe were notified mid-September. So they're wading through SAMHSA paperwork and trying to also get a program off the ground.
I mean, I think that just to kind of give yourself some grace and know that it takes a little while to get everything really running smoothly. And I think that that's part of it, and it's expected. I know that I personally felt a lot of pressure the first year, like we had to fix everything and that every client had to be a success in every way and that we couldn't fail at all. And that ended up not being the reality of what we were doing at all, right? And my mindset it now more is we will do the best that we can with every situation and every participant who we work with, and that's really kind of what we can do as a team. So we kind of learn to sort of work through that expectation a little bit. I also remember being in this meeting 4 years ago as a new, very anxious grantee, and someone saying, like, the 4 years will go by so quickly, start planning for it very early. And I have thought about that statement more times than I can count over the past 4 years, and it was absolutely accurate. It really flew by, and I felt like we maybe didn't start having those conversations as early as we should have, right? I didn't heed that advice, but just start thinking about and planning and talking about what this will look like, right? As your SAMHSA time comes to an end, how to build a program that is sustainable after that time.
Jessica?
Okay, so being that I am working on my no cost extension right now, I'm going to say, one, make sure that you know the difference between instructions and a template when talking to your GPO. If you ask for instructions, you will get the instructions to ERA comments. If you ask for a template, you will get what you're supposed to write to submit to ERA comments. I also recommend that now some of you might be entering the NOMS data indirectly, or your centers might. Everyone looks a little different. I keep a separate spreadsheet for my NOMS data so that I know how many people at all times we've had enter the program, who's done their 6 months, who has left the program. Now, I don't have names. I do recommend that you start the recidivism chart. If Amy hasn't sent you that yet, the Excel spreadsheet that TAC has put together to track your recidivism, track it. You want that data. You can't prove your program works without data. So the more you can say, hey, okay, so for instance, I'm gonna brag a minute. Kansas had 100% recidivism rate over 3 years, 100% reduction in recidivism. Sorry, no law enforcement, no rehospitalizations, 100%. We've got one. We got one that came back, so we're at 97. But when I can tout that data and back it up, that's what you really need. Because if you're going to go to the legislature for funding, You have to have all your data. Track your data, collect all the data, and keep it organized because you're going to need it later. The other thing is take it slow, but not too slow. Our first year, we spent a lot of time working on manuals and forms and trying to make those connections, and pulling that trigger to take that first participant was like pulling teeth. No one was ready for it. You're not going to be ready for it. Take that first participant and start working through the process with them. Unfortunately, somebody's going to have to be a guinea pig. Plus side is they're going to get a whole lot of individual attention. So take it slow. And then once you get comfortable with one, add another, and then add another. And you'll be surprised at how fast your program grows and you're moving smoothly. And also make friends. Your team is important. You've got to have a good team, be it spread out 4 hours away from each other or whatever. Keep in touch and be friends, not just colleagues. You need to be able to vent and bang your head on something.
So, obviously, SAMHSA funded. You have frequent contacts with SAMHSA, your GPO. How'd that go? How were they helpful, and how? Well, let's start with that. How were they helpful to you? And it's okay if they weren't, because SAMHSA is not on this call.
We had, I think, four or five different GPOs. It was kind of a revolving door. Some of them were interim and had never worked on AOT or knew a lot about AOT or what we were doing. So I don't know that those meetings were incredibly helpful, other than we touched base once a month, and they would just kind of at least ask questions so that I could check in and make sure I was on track with things, right? Like, are you guys doing your NOMs? Did you turn in your IPP data? Like, just remember that this is coming up. But it was pretty surface for us. We didn't have any major issues for them to tackle, so I didn't get to really test that out. It was just a pretty surface level relationship for us.
For us, it was a little different. My first 6 months on the job, well, they handed me a notebook and said everything's beautiful and everything's great. Someone ran over my favorite sweater, set it on fire, and then gave me the wrong color yarn to stitch back together. That's where we started. I had no idea. It took me 3 months to figure out who my GPO was because they were on vacation. We were in COVID. It was a mess. Finding out who was handling my finances and the budget that I needed to do was more difficult. Getting instruction was even more difficult. So we meet monthly. I've had the same GPO since, I think, year 2. And we meet monthly. And she's helpful, but you need to learn the terminology. Like I said, the difference between instructions and a template. You need to know what you're asking for, because if you don't know what you're asking for, they're going to keep sending you the same thing over and over again, and it's not what you want. Also, I do recommend you go to the webinars. Again, most of them are how to work ERA Commons, or how to, navigate system, but it's important because if you don't know how to navigate that system, you need to learn. And then follow up with questions. And if they're confusing you, go to their counterpart. You have 2 for a reason. I mean, granted, one does finance and one is your project operator. But I really recommend that you check. One of them has been there longer, and one of them knows what they're doing a little more. Because if you don't, you're going to end up like I am, which is slightly confused and baffled and not really knowing what I'm supposed to do. So, ask all the hard questions. Don't be afraid, and have them research it. It's their job. Truly, it is their job to guide you. They do what I do, only up there. So ask the hard questions and don't be intimidated.
I will say that I have not had an AOT grant, but I do know some. I have had other SAMHSA grants, and my GPO was very established, was very knowledgeable about the subject matter. And that is not the case here. These GPOs are not, AOT is such a niche program that your GPOs are not subject matter experts. So just keep that in mind. But my one thing my GPO did do, well, she was a subject matter expert, but one of the things I found helpful was connecting me with other grant programs that were experiencing the same issues. So
Let's see, Amy, that was you for me. That was TAC. You guys made those connections for me.
well, thank you. That's our job. That's what we love to do. Because really, our goal in this whole thing is to make sure that you guys have the best programs that you can, because in the end, our goal is to promote AOT and wider adoption of AOT. And if you all don't have great programs, that's not going to happen. I'm going to ask one more question, and that there are several requirements from SAMHSA, and I'll say, Kena and Jessica, this cohort has a lot more documents required of them up front than y'all did. But several requirements: grant management, end of year reports, applications, budgets, NOMs. What were the most challenging, and how did you work through it?
For us, definitely the noms. Getting those all completed, keeping up with them, doing a nice job with them, because that could be really challenging in some cases if you have someone newly discharged from the hospital and not necessarily ready to answer all of those questions. I think the biggest thing we did is for our we would do all of those assessments in the field. I think it would be really challenging to expect everyone to come in to you to complete that assessment. I think that you could struggle a little bit with getting them done. I would send staff into the field and find people and make sure we got them done that way. And I think that after like year 2 of the grant, they simplified that assessment. SAMHSA simplified the NOMS assessment considerably. So it is much easier now to get through with clients. But definitely that. I mean, it's a lot to keep up with.
With NOMS data, first off, when they changed it and they simplified it, we lost half our data. So things got a little more complicated because you can't compare somewhat and yes and no. It doesn't work well. So we lost most of our first 2 years of data, but we do have our people come in to collect NOMs, but we bribe them. They know that if they come in and they do their baseline, their 6 months and their final, and it's really the final one that I'm really wanting. We give them a gift card. It may be $5. It may be, I think $20 is the cap. I will say getting incentives on the budget for anything other than data collection is extraordinarily difficult, and be careful how you word it. They've now approved, I guess food is now a basic need. That'll work too on your budget. Again, 40-page budget, guys. All 5 centers had a detailed budget down to the mile. So if you need budget advice, I'm happy to help anybody because I've been there 4 times. But the budgets were hard. The noms, we've done a pretty good job. I don't think we've ever had to really bother anybody other than the 6 months. It's kind of like we get rolling, they start doing great, they forget about the 6 month. But that's why the check mark is for the client you can't be reached for interview. But the incentives have helped. People show up if they know that they're going to be in a raffle, if they show up for docket and they might get a gift card. They show up for NOMS data. Snacks work too. People show up at one of my centers just for the snacks, and I think they've got like a $4 a month budget. They're really, but snacks, anything, freebies. People like free stuff. But right now, the other issue that I had to think about was the difference between a carryover and a carryover. Again, learn your technology, or whether you're just carrying it over to the next year to the tack onto the end, or whether you're needing an extra pot of money. Get your glossary out and figure out what the difference is between a carryover and a carryover.
I think Kane is like learning something. I've only heard of carryover.
I am.
Yeah, there's 2 types of carryovers. One where you actually get the money, and one where it just carries over to the next year. And then you can maybe do a no-cost extension at the end. But they'll just call them both carryovers. It's very bureaucratic, says the state employee.
Yeah, it is extremely bureaucratic, but it is the federal government after all. All right, audience, we're gonna open it up again. We're not gonna take raised hands. Please put your questions in either the Q&A pod or the chat box, and I'm going to turn it over to Shanti.
Hi, everyone. Jessica and Kana, that was great. I also learned a lot. I'm going to take a look. So any of you who are here, feel free to put questions in the Q&A or in the chat. I see one question in the Q&A that says, if you've ever experienced the office hours providing conflicting information from your GPO, how did you make a determination about what to submit or whose guidance to follow? I'm guessing office hours refers to advice from TAC, but if you were the one who submitted that question, please clarify. So I guess if you had a TA provider who told you one thing and your GPO told you another thing, whose advice would you follow?
Depends on the report. If it's my budget, you go with that one. If it's my end of the year report, you go with that one. Or you double down and you answer it both ways. But I would go with whoever gave you the advice, depending on if it's their report or not. That's what I would answer.
Oh, it was the person who
SAMHSA.
said, yeah, SAMHSA office hours versus your SAMHSA GPO telling you conflicting information. Then what do you do?
I will also say that in my experience, that is not surprising where you get 2 different answers from 2 separate people at SAMHSA. And that's a good question. I don't think I would go with the GPO because they're the ones who are going to have to advocate for you in the end if you run into problems.
Great, sounds good. I'm going to move on to the next question, but Debbie, if you have any more thoughts or want more clarification on that, feel free to put something else in the chat. I have a question. This is from Betsy on our team, asking, Jessica, you mentioned that getting the state hospitals to make referrals was a top-down process rather than a bottom-up process. And can you elaborate on that?
What we found was, okay, so we have hospital liaisons for all of our centers in the state hospitals or that work with them. And going to the in-hospital case managers, clinicians, and then trying to get to the psychiatrist who would eventually have to sign the orders wasn't working very well, because you were starting with people with little power or no power, trying to explain to someone with more power how this works. And that never works well. It's kind of like how judges only talk to judges, police only talk to police. You got to start with the top. So what we did was we started up with the directors of the hospitals. And that may take some finagling. That may require you to tap, someone above you to say, hey, I need you to tell this person about this program. Then we started calling on a meeting. So for our case, we used Johnson County because Johnson County is the largest, well, it's Kansas City, but they're the largest city in the state and with the most amount of money. So, and we have an amazing judge there who said, hey, we're going to start meeting with one of the state hospitals now. And he would start calling monthly roundtable meetings, and they'd work through all of the nuances of what we need to do to get AOT to Johnson County. But to do that, I needed the judge to have the power to pull the head of the state hospital and the psychiatric team on board to talk it down. But we moved a whole lot faster after that. After meeting one, referrals picked up. Whereas we'd spent 6 months pecking at the bottom tiers and getting nowhere. It's about buy-in. You have to get the buy-in from the top down. And if that means you've got to get your directors involved, then just, buy them a coffee, ask for a favor. They believe in this program or it wouldn't be where it is.
Kena, do you have any thoughts on that or similar things that your program might have had to do to get these connections made?
I would imagine that it was probably a fairly similar, I think a lot of that happened before I was hired on, but I think that it was probably a pretty similar experience to kind of having those meetings between kind of the heads of our agencies and HCPC or BenTOB and kind of starting there and getting everybody on board.
That makes a lot of sense. And I'll say too, since everyone on this call is kind of at a place of very soon having their steering committees, having to have those in, and having their names of all their collaborators to start really thinking about who needs to be at that table before that 6-month due date that everyone has coming up for their grant deliverable. See, I'm going to do Stetson's question and then Brian. So Stetson asked, for Medicaid programs, how have you navigated referrals when they do not have qualifying insurance?
I think for our agency, we typically prioritize clients who are uninsured, and they go through our kind of general revenue funding stream. So that is really fairly typical, and I think could be more complicated for other programs from what I have been told. So I don't know if Jessica may be better to speak to that a little bit.
I can try, but I believe we are a rarity now. Again, we have that gap. Our state legislature would rather pay money back to the federal government than to pass Medicaid expansion, and they have. So what we do usually for those gap clients is, one, we will try to get them on Medicaid. That's step one, because there may be a reason they're not on Medicaid. Step two is, if we can get them on disability, great. If they, qualify. So we look at the services that they can qualify for. Then again, I budgeted that pot of money, because if they can't qualify for Medicaid, they don't fall into the CCBHC model. So most of our centers will have a income-driven scale. So depending on what their income is, depends on, how reduced that fee is, because they're not going to turn folks away, especially not from a grant-funded program. And then if all else fails, then they dip into their grant money that they budgeted for them, and they pull that through. But I do recommend that if you've got a gap, you budget for that because you're going to need it. Or you may not. I mean, I have some centers that never touched that money, and I don't know how they were paying for things, but they had something set up, be it charitable or otherwise. So, but yeah, you want to plan for those participants because you don't want to tell them, I'm sorry, I can't help you because you don't have any money. And you don't want them stressing about $1,000 bills either.
Yeah, and I'll say as well, the Cindy Gibson, Dr. Cindy Gibson, who was not able to join us today, she put in a little plug for creative problem solving, especially for some of these funding gaps. I know she is talking about recently, her center has been even looking at the vending machines that they have, and can we take this money and use it for co-pays so that our clients aren't stuck with these bills for medication. So starting to think about these things as early as possible will put you in a much more comfortable spot to deal with things as they arise. And Brian's question, can you elaborate on how you were able to have gift card incentives for follow-up visits as an eligible SAMHSA expense?
I'm going to assume that's me.
That's
Unless, Dana, did you guys use incentives? No.
No,
Okay.
no, we didn't.
So I didn't write the initial grant, but it was in my initial grant application that we would do gift cards for data collection only. We've expanded on that a little bit, because you've already got the cards, but so we do those for raffles for some judges. Some judges are safe with it, and some feel that it's bribery, and they don't feel that that's okay. But I wrote it into the grant. They gave me, I think it was $20 or $25 per participant for 2 data collections. So you could, and that was budgeted. So you could do a $25 gift card, for the initial baseline, and then for the 6 months, and then follow up, I guess you were on your own. But what we did was we took that $25 and split it down into $10 gift cards, or some 5. Sometimes it's a $5 Starbucks coffee. I don't know if you can get a coffee at Starbucks for 5 anymore. But and we would make sure that it was things where they couldn't purchase alcohol or nicotine, those kinds of things. It needed to be something that was relatively fun, but yet useful for them. But I budgeted it in, and I explained why I needed it. And then we cut the amount down and used those for other incentives, like showing up for docket. We haven't done treatment, but it's all court related or data collection related.
I think this will be our last question unless anybody else wants to.
Hang on.
Go ahead, Amy.
I just I want to make it clear that somehow Jessica got around the system, because it's very clear it was very clear in her NOFO that you could use incentives for data collection only. And for some reason, I'm not sure why, you could only use it for the second and any following data collections. You couldn't use it for the initial data collection, which made no sense to me. No sense. But there you go.
And it's possible that the court system, those are donated gift cards. I can't track all 5 of them, all 5 centers for $5 here and $5 there. But I did write it into my budget.
And for those of you wanting to use incentives like that, there are creative ways to fund those. And keep in mind, they don't have to be huge. One way that I think is very helpful is to check in with your local NAMI. It's not a huge expense, and they want to be helpful, and just an idea. So,
and it doesn't always have to be gift cards. Swag works too. You can do t-shirts, cups, keychains, mittens, gloves, socks.
I think the excitement of getting something free is a very universal human experience.
Yeah.
It's the most powerful word in the English language.
Great. So I think because we're coming up on the hour and I want to be respectful of everyone's time, I'm going to pose Stetson's question, which is how do you navigate judges or court systems who are resistant to AOT? But I see that Melissa also has a question, so I am going to take a screenshot of this question and we can follow up with you if we run out of time so you can get an answer to that.
So we're using the judges in the court system question.
Yeah, judges and court system. First come, first serve.
The first thing I do is I send in a judge. I send in another judge. And that is something that I have the advantage to because, like I said, I actually have 6 programs. 5 of them are SAMHSA, 1 resistant judge, and we sent all the judges. He's not budging. But judges talk to judges. They speak their own language. And no matter how much you learn and how much you research, you will never be able to speak the language like a judge does. So you find someone who's friendly and you have them go talk to each other. And if they don't hit it off, then you get somebody else, a different judge, preferably. And you can cross state lines. They may not have the exact same statutes, but they still speak the same language. That's how we find, and I've had resistant DAs too. And that's how I get the DAs. I send it up here. It just makes it simpler. And TAC is an amazing resource too. Reading off.
Hannah, do you have any thoughts on that question before I kind of wrap us up for this hour?
I mean, thankfully, our court has been pretty committed since I joined on, but I do think that they also modeled a lot after San Antonio's program and speaking to the judge there. And so I think that that was really wonderful advice that Jessica gave.
Yeah, and I'll say too that it is possible to have a very successful program where the courts and judge are very involved and very on board. And it's also possible to have a very successful program where that's not the case. So it's kind of a matter of working what you have with what you have in your jurisdiction. Let's see. Well, I guess I'll bounce to Amy. What do you is everyone available to go over a little bit, or should I go ahead and wrap this up? To Amy, and then also Jessica and Kayna, I want to be respectful of your time, but it looks like we do have a few more questions that are coming in.
Yeah, it's up to Jessica and Kayna.
I don't have anything right after this.
I'm open also.
Great. Well, let's go ahead and go through questions as much as we can then, so everybody can get.
Actually, let's limit it to 15 minutes because Kayna's doing this on her day off.
Oh, Kayna, thank you for coming.
No problem. I'm happy to be here.
Yeah, so we'll do Melissa's question and then Megan's question, and then I think we'll call it. So Melissa's question was, it sounds like both of you are getting referrals from either county hospitals or state hospitals, but she doesn't have a county hospital in her county, and most of the individuals in the state hospital have been ordered there for competency restoration and then are sent back to jail. So they're not quite sure. They're trying to figure out referral sources, and we're wondering if you had any suggestions about that.
So your state, I mean, my state hospital does competency and restoration as well. I mean, that's why they're there, is they reach that dangerous left or other inpatient commitment level. And then they're, competency and restoration, they go before the court or they're discharged. Because our state hospitals have the authority to discharge whenever. What I'm wondering is if there's a couple follow-up questions. Are all of your folks coming from jail?
So some states, they use their state hospitals solely for competency restoration and GRI. They do not take civil. So that's the rub.
Then I'd look at private inpatient facilities.
Yeah, wherever your civil patients or the people in your community, wherever the non-criminal folk go, are your um, are your referral sources. Jails can be referral sources, but you want to be careful with that. And we have some recommendations regarding that. But the folks who need AOT are going to the hospital somewhere, most likely. So figuring out where that is part of the battle. Back to you, Shanti.
Yes. Next question, a follow-up on the question about judges. So I know that we've talked about getting a judge to connect with another judge, and that can be really helpful. Megan was asking, what if you can't connect with the judge at all? So they've found, she says, for example, getting a meeting is near impossible, and we are told we can only have 10 to 15 minutes.
Take your 10 to 15 minutes. You want that 10 to 15 minutes. Don't squander that. That's important time. And you have to go in and you have to sell your program. And then you bring in another judge or utilize TAC and have them help you out with a network of judges nearby, someone who can sell the program. Even if it's just sending a short video. Judges have no time. They're overworked. They really are. Their dockets are huge. Take your 10 to 15 minutes. Step one. And then follow up. Once you sell it and you get the right judge, you'll be glad you did. But if you don't show up, you're never going to get them because they don't think you want them.
Betsy, do you mind jumping in here with that question?
Sure. No, I think Jessica nailed it in terms of absolutely take your 10 to 15 minutes for sure, and be thoughtful about that. And certainly TAC can help you think through that, but bring somebody with you. Most judges are elected. I know some are appointed in some states, but for the most part, I think they're elected. So, you know, if you've got an active NAMI in your community and they're on board with this program, bring their executive director with you. If you've got a family that can tell, you know, to share a story about what they've been through with their loved one, you know, personalize it, bring TAC and help you, arm you with all the data you need to make the case. And then you can offer things like, you know, would you be open to talking to another judge with a successful program? Would you be open to visiting a successful program? You know, there's all sorts of options. So yeah, be thoughtful about how you're going to make the best use of that 10 to 15 minutes. But that's not unusual for them to limit. And chances are, once you're in there and you've got their attention, somehow that 15 minutes will likely turn into 30. So be prepared for that as well.
And that is also something that if you send us an email and you're going into this meeting and you want to make sure that you're hitting all the right points, we've worked with a lot of programs who have had to go through this process to get a reluctant judge or a reluctant court system on board. So definitely reach out. I think that's going to make the end of our webinar. Thank you so much, Kena and Jessica. Thanks everyone for coming. We will be sending out a recording of this webinar along with some follow-up information. I did want to remind everyone just before the webinar wraps up that this will be the end of our complimentary webinar series. And so kind of, you know, as a reminder, in the NOFO that you all have, there is a requirement to engage with outside consultants for your training, evaluation, data collection. Of course, that doesn't have to be us if you have another TA provider you have a good relationship with, but we enjoy doing this work. We think we can be helpful and we'd love to stay engaged with you all, answer your questions, give feedback on documents, that sort of thing. So if you'd be interested in watching the rest of this webinar series, we'll have a lot of really interesting speakers coming in. We'll also have group office hours, individualized support. We can do on-site trainings. There are many, many things that we can do when it comes to technical assistance to help you. So you don't have to feel lost or like you're wandering in the dark, like it often feels like at the beginning of these SAMHSA grants. So if that's something you're interested in, feel free to reach out to any of our individual emails, or we also have our aot@tac.org email. Yeah, and I think with that, the webinar is concluded. So thank you so much again for joining us. Big thank you to Jessica and Kana again for your time. I think this has been really, really helpful. I'm very grateful for it.
Thank you. And have a great rest of the week.